Good evening, everyone. Myself, Dr. Shravani, Clinical Head of the Emergency Department working at Yashoda Hospital, Somajiguda. Welcome you all for today's webinar session. Every Friday, we Yashoda Hospital comes with few interesting topics. Yet today, we have one more interesting topic, that is infectious disease in the emergency department. It's preparedness and response. So, as many of us know from daily practice, the emergency department is often the first point of contact for the patients presenting with undifferentiated symptoms. Some of them are emerging or highly transmittable infectious diseases. This makes the emergency department not only a front line for acute care, but also a critical setting for early detection, containment, and response. So to deliver this talk, we have one of the eminent speaker who is experienced for almost 22 years in the medical field. I welcome Dr. Raghu Kondle sir, who has done his MBBS from Usmania Medical College and MD from Sri Ramachandra University. He's a gold medalist. And he has also done diploma in diabetology, fellowship in critical care medicine, and fellowship in International Science Academy. And he has done PhD in medicine from Lincoln University, has done MBA from BITS Pilani, and previously worked as a head of the Department of Emergency and Critical Care Medicine at Narayana Medical College Hospital for almost 16 years. And he has also done more than 50 research publications. Now, Dr. Raghu Kondle sir is currently working as head of the emergency department, Yashoda Hospitals, Malakpet. So, welcome, Dr. Raghu Kondle sir, and over to you, sir.
Thank you, Shani, for the kind introduction. So without wasting much of the time, I will directly go into the topic. So as we know, I strongly believe the first 15 minutes of any other specialty is nothing than the emergency medicine. Maybe it is small fever to the life resuscitating, saving life. So the first 15 minutes, so we get exposed to whatever thing, as Dr. Shravani said. So we are the frontliners for maybe a small thing to the life endangering services. So the objectives of today's topic will be early identification of infectious threats, safe and efficient isolation. So implementing the identify, isolate, and inform strategy, and integrate universal screening and PPE protocols, collaborate with the infection control and the public health systems whenever there is a pandemic or whenever there is a outbreak of any infectious disease. So the image shows that how much it is important in the hand hygiene before touching the patient or after touching the patient. So how we define highly infectious disease? These are communicable disease that can spread rapidly, cause severe illnesses or death, and may have no immediate effective treatment or vaccine. So we have the examples of Ebola, Nipah, COVID, MERS, Avian influenza, smallpox, measles, TB, viral hemorrhagic fever. So as we all experienced the COVID pandemic, which was there from 2000 to 2022, the last pandemic which we experienced. So the key mnemonics, the 6 I's for the ED, high infectious disease, will be your identify the disease, whatever it is. So next thing is you should isolate as early as possible and inform your authorities. So whoever is heading your hospital admin department, then implement the isolation protocols, then coming for your investigation and involve everybody whoever is involved in the management of these infectious diseases. So coming to the background of this, you can see the wide distribution of all these infectious diseases widely across the globe. So annually 15% of all deaths worldwide are directly attributable to infectious diseases, and it remains the second leading cause of death worldwide. Although the rate of infection disease related to deaths has decreased drastically or dramatically over the past 25 years because of maybe the protocols what we are following, vaccines which we developed. So it has come down, and highly infectious disease is equal to highly transmission with highly mortality, as we saw in the COVID wave first which was and the COVID wave 2, where we had the high mortality. And the historical outbreaks, SARS in 2003, MERS in 2015, Ebola in 2014, and COVID pandemic 2020 to 2022. So the common factor for all these, your delayed recognition and isolation in the EDs, because we are the frontliners. And EDs are the frontline for detecting and containing outbreaks. So there may be some delayed recognition, but we are the frontliner for detection and containing all these outbreaks. So how we define emerging versus the re-emerging infectious disease? So emerging infections are newly recognized in humans or rapidly increasing in incidence crossing the geographic range. And re-emerging are previously controlled, but the slowly upward trends in the incidence or resurgence. If you take the emerging infections with your Zika and MERS, re-emerging will be dengue, chikungunya, and tuberculosis. As we see this periodical outbreaks of dengue, one a year we see there will be nothing. The next 1 or 2 years it gives a rest again, it rebirths. So this year, luckily, we don't have much of the dengue outbreak cases. So these are the differently cases widely distributed across the globe of newly emerging, re-emerging, and deliberately emerging case fevers. So what are the drivers of emergence and re-emergence? So because there is an increased global travel and migration where there be a contamination causing these emergence and re-emergence cases, urbanization, deforestation, encroachment into the animal habitats, that is also causing a major issue, and climate change and vector expansion. So when there is a drastic climate change, we see all these flu viruses, and weak public health infrastructure and detection system. So if you go this rural population where we have the weak public infrastructure and detection of these infectious diseases is also hampered there, and zoonotic spillover and novel pathogen adaptation. So these are some of the drivers of emergence and re-emergence. So initial recognition, triage, and early suspicion. So this plays a major role for all our emergency physicians because we are the frontliners. The goal is identify and isolate before the exposure spreads. So at triage, what you should do, ask a travel history, recent travel to any outbreak areas in the last 21 days. Ask any exposure history, contact with any sick persons, animals, or contaminated material. Simultaneously, take the history of any what symptoms they are presenting with, any fever, rash, bleeding, respiratory distress or cough, neurological symptoms, or even your GAE symptoms, whichever can give a clue of the existing pandemic or the pandemic which has been recently addressed. So what we should do, identify, recognize the potential highly infectious diseases case, isolate, place in a single room with a negative pressure if available, or inform the authorities regarding your isolation protocols, and inform and notify your infection prevention of your hospital and the local public health authority, so that you can contain your infection spread. So this image shows how the pandemic in the COVID era, where this patient has been transported with an O2 cylinder on the bike for a searching of the bed. So these articles published in 2021 and 2020 were the infection disease in an era of a global change and the One Health approach of infectious disease outbreak controls. So this article, which was published in the Chinese journal in recent past, 1.5 years back, so the indispensable role of emergency medicine in the national preparedness for highly consequent infectious diseases. So how they made that? So all the infection cases, whenever they have seen, So basing on the symptomatic cases and what are the control cases, hospitalized, severe, and what are the death cases. So basing on all the infections cases, whatever which has been presented to the ED, so what are the symptoms they have, what next they isolated the control cases, then they have notified the hospital cases, and how many are the severe and what are the death cases. So this had made a platform for everybody for the next how to contain a pandemic. And this article, the original research published in last year. So this was again published in the Infectious journal, where there's a global distribution and health impact of infectious outbreak from the last 1996 to 2023, a worldwide retrospective analysis of the World Health Organization emergency event reports. The study also emphasized on growing threat of the vector-borne and waterborne diseases such as the 2023 dengue fever outbreak and the 1998 cholera epidemic. So particular regions with an inadequate healthcare infrastructure. And lastly, this article, which was again published in the Chinese journal. So infectious disease control from the health security strengthening to the health systems improving at the global level. So what you should do at the global governments, that means from your administration perspective you take. So first we take from the emergency department. So how far is the emergency preparedness and response whenever there's a pandemic is there, and disease surveillance from your IPC, and lastly your evaluation tool. So if you take from the system strengthening from the administration part, so the leadership and the stewardship, health financing, health workforce, medical protocols and technologies, information and research, and service delivery. So it is not a one-man job. It is linked everything between the doctors with your administration part for the global control of your ID infectious diseases. So why the EDs are vulnerable? Because you see many EDs will be always flooded. So the crowded environment where there's a high turnaround increases the infections risk. So all presenting patients to the ED with a travel history or without travel history or exposed, they may not be giving the history unless until you go in depth. And they may be sometimes presenting with your non-specific symptoms, so which will be very difficult for your early initial recognition becomes very difficult. And some places where you have a lack of screening facilities and the PPE scarcity will be there, so which increases the nosocomial infection spread. And lastly, your limited triage isolation. So you may be only keeping or one or two triage beds where, so at the time a surge of patients coming, so it will be very difficult for the limited triage isolation because these are your order layouts. So as time is going on, because now all EDs are coming with a triage with the multiple beds with the initial screening and isolating initially if the patient is being a suspect in your negative pressure room. So what are the key lessons learned from your past outbreaks? The first one is the SARS. So what was the failure point there? So it was missed early isolation. And the lesson learned is travel and cluster screening are very vital. And the MERS virus, which was there in the Korea. So the failure point was your ED overcrowding. So this is same image what was showing. This was the Korean hospital with the overcrowding. And the lesson learned is your airborne isolation as early as possible. And the Ebola 2014, which was in the Dallas, New York, US. So the failure point was your missed travel. The same patient had traveled multiple EDs without giving the history. So even the doctors in the ED couldn't ask for the travel history there. And the lesson learned are implement the identify, isolate, and inform. And the lastly is the COVID-19, the failure point is PPE, fatigue, and aerosol spread. So the lesson learned is preparedness must be sustainable. So these are your examples of this thing. The first thing image shows your Ebola with the spread, and lastly your COVID-19 deaths, which was the last 2 years. This is the same diagram. So this is your MERS outbreak in 2015 in the South Korea. With the last, for the 3 months it was there. So the blue line shows the infectious, and the red line shows the death, and the orange which shows the patients have been quarantined. And this background shows the number of coronavirus cases so far has been exceeded the total number of SARS viruses. So if you take this, the COVID cases exceeded almost in 1,000 when you take this thing, and the deaths, if you take, the SARS has more death than your COVID-19. So what are the things you should take into point whenever you are working in your ED? And so as we will be geared up for all the epidemics and pandemics, the same thing should be followed. So mandatory travel and symptom screening at the first point of point. Whenever there is a outbreak or whenever there's a surge of symptoms, will be seeing in your ER. So at the first point of contact, that is nothing than your triage or your front desk. So ask about the flu-like symptoms or any other symptoms which are continuously persisting in last 2-3 months if you are thinking there is a pandemic going on. And if you find out those are things, provide surgical mask to all whoever is having your flu-like symptoms so that you can contain or you can stop the spread. So use the updated outbreak alerts from WHO, local health authorities. So nothing but how we deal with the pandemic. So the first thing is your vegetation, then your preparedness, response, and lastly your recovery. So these things has to be taken into control whenever you are doing a universal screening in your ED. So these things which we saw in the recent outbreak in the COVID-19, so where most of the doctors, the precautions taken whenever you are examining the patient. So different methods were there. So in this diagram, you are seeing the doctor completely covered with a screen and examining the patient, and where the testing of the nasal swab by taking, this is the Korean model, where the hands have been extended with 2 things and collecting the swab. And this thing again, which was done in the Tamil Nadu, where the patient has been, whoever is entering there, the decontamination with the fogging through the tunnel which was placed. So the different methods were being implemented
to the market to shop have to
during
wash their hands
this
and walk
COVID
through the tunnel
pandemic.
for 3 to 5 seconds.
So they have to walk
During
in
the
this
sodium
tunnel
hypochlorite
for
and
3
water
to 5
mix is
seconds with
cleaned
your
up in a safe
sodium
manner.
hypochlorite, which was read to.
Portable Corona disinfectant tunnel is a 16-foot stainless steel structure fitted with nozzle sprayers inside. Tirupur-based entrepreneur D. Venkatesh, who runs a water treatment company, has built the tunnel by collaborating with district administration.
So the next thing is your 3 prolonged approach, that is identify, isolate, and inform. So for the effective disease control, the first thing is identify. So recognition the symptoms at risk at the initial triage level. Then as soon as so you have to isolate these patients, separating from your infected from your non-infected individuals. Then informing the authorities. So what is first thing is your hospital administration and the local health DMHO, whoever is this there, alerting about the pandemic. So identify, isolate, and inform. So if you take these infectious disease, what are the recommendations and when you are vaccine isolated. So Ebola, you need 21 days monitoring and quarantine. And you have a vaccine, Vivo and Zabendo. So 2 days. So this has been given during the regimen during your outbreak. And the Nipah, you need a 3 weeks isolation, no approved vaccine. COVID-19, we need 5 to 7 days. So we have different some people have taken a first dose followed by a booster 1, booster 2. And the next is a MERS. So it has a 14 days isolation. There's no vaccine. And the avian influenza, as we see this it depends upon the strain. And so for this, we are taking the seasonal vaccine. Measles, all we know, it requires a 4 days. And we all give for the children the MMR vaccine. And tuberculosis, it is a 2 to 4 weeks. So after the birth, we never miss BCG vaccine. And lastly, the smallpox, 3 to 6 weeks. And thank God it has been eradicated. So lastly is triage and outlet optimization. So all the triages, it should be have a isolation rooms near the triage to avoid the patient movement. So if you are not having regularly, at least whenever there is a outbreak or the pandemic, you should create a isolation rooms to avoid the patient movement. And clearly there should be a marked red zones that is indicated in the for your suspected case and dedicated donning and doffing areas whenever these patients have been examined, transported, and maintain a visual flow posters for all the infection screening. So as you see in this diagram, there's a beautifully layout of the patient. So PPE and the safety, staff security. Challenges are the comfort, training, and retention of PPE proficiency. So there has been a scarcity of PPE in some centers during the pandemics. So according to the recommendation is Yaffe et al., streamline the PPE to maximum protection with ease of use for the frontline staff. A simple donning and doffing to minimize the error has to be taught to all the staff, and regular drills and buddy checks for the mandatory. So these are the different PPIs which I used during the COVID. One is a simple helmet, then with the this thing, and lastly, different types of being used during the COVID pandemic. So this diagram image shows that how we and the stepwise protocol we followed when we were donning a PPE. So I don't go at the depth how donning and doffing it is required. So this image shows a standard PPE. This is a full PPE and a enhanced PPE. So it is the availability of the PPEs we use, and basing on the extensive or the procedures, we can modify our PPE. So the next thing is case definition refinement. So nothing but develop a practical person under investigation criteria, like combining your clinical symptoms, travel history, exposure risk, and illness severity. So if you have a case definition refinement, it will be easy for all the persons. So it helps always prevent the alert fatigue and unnecessary research use, because all the pandemic, there will be a lot of research and resource using. So the scarcity will be there. So you should use accordingly. And the example, the CDC tied a case definitions for MERS, Ebola, and COVID-19. So the electronic system which was there initiated, then the examination reports, then the data center which was there, then the results which have been announced. So whether the patient has been any infectious or whether the patient is not infected. So that if you have a case definition refinement, it will be easy. So the next thing is negative pressure rooms. So all ED having isolation with negative pressure rooms may be Herculean task because of the financial constraints. So whenever there is an epidemic, so availability of negative pressure rooms has to be considered and used accordingly. So these things has to be displayed during the pandemic. So what are the precautions the visitors has to take? What are the contact precautions and what are the droplet precautions? So these has to be displayed everywhere to contain the infectious. So the next thing is immediate clinical management. So once the patient has come to the ER, basing on the condition, so we initiate the ABC stabilization with the full PPE on, and we try to avoid aerosol generated procedures unless it is essential. And we manage alternative diagnosis also. If all patients may not present the same thing with the pandemic. So for example, the malaria sepsis cases also has to have a alternate diagnosis also, and avoid delays in the treatment due to fear of uncertainty. So if you take this triangle, once the patient has come with a full PPE, you examine the patient, you do it, and you administer the change of workflow. And so, as we said, substitution of the and replace the hazard. So if you have a nebulizer thing the patient needs, so you can use the alternative meter dose inhalers instead of using a nebulizer where there is a aerosol spread. So the elimination remove the hazard. So once the vaccine has been available, the vaccine should be made available for all the patients. So the next thing is rapid diagnostics. So the gap identified due was the limited access to rapid tests, whether it's for viral hemorrhagic fevers or the MARS, etc. So the recommendations were expanded use of rapid diagnosis there and point of care testing. So this has to be made available whichever hospitals or centers are notified or labeled as a pandemic hospitals, and a local lab should enable faster confirmation results to reduce the PPE burden and ED congestion. So the hospital attached lab should have a faster a rapid card method, or if you have point of care testing, that will be very helpful. So use of point of care test wherever it is available should be used. So the immunoassay, the cultures may take time. So the rapid method, so whichever it is there, so and it can be confirmed laterally. So next one is communication and notification. So in the predefined chain in the ED, so whenever you have these surge, so you alert the infection control practices personnel, so which then later been addressed to the hospital administration, and lastly your public health authority system, so where they can take the measures to contain it and avoid the spread of it. And we should use the structured templates to report the suspected cases and maintain a log of exposed staff and ensure confidentiality and calm public messaging, so that there will be a avoidance of a chaos there. So it should be in a confidentiality and a calm public message. Next comes your decontamination and the waste control. So when all these PPC used, or whenever there is an exposure or droplet infection. So after each suspected case, the surface cleaning with a 1% sodium hypochlorite or 70% alcohol, how we use in the COVID, has to be maintained. And the proper waste segregation, this plays a major role from the biomedical waste management, and terminal cleaning after discharge or transfer of each case. So from the ED to the last discharge, a proper decontamination and waste control has to be taken into control. So training and drills. So conduct necessary patient drills used in the New York in the 2016 study. So result shows 83% success for MERS and 74% for the measles. So after this study, when they had a mystery patient drills, so they had 83% for MERS and 74% for measles. Yet 39% hospitals failed because you may not have a 100% accuracy always, and they should be having a predefined infectious disease pathway on posters in the triage. So whenever you have a pandemic, you are expecting already running, so you should have a predefined pathway posters for the local public and the hospital. And regular mock drills and training should be done for all the hospitals. It can be a 3 months, 6 months, or 1 year at least. And designated isolation and red zones whenever the pandemic has started. And availability of PPE kits, disinfectants, and rapid test kits, there should not be any shortage. And liaison with the always with the public health authorities. Inform the government officials, so don't take anything an individual. So the pandemic preparedness, the government involvement or ownership should be taken, and biosurveillance and early detection and reporting the rapid response, and ongoing global clinical trial capacity preparedness plot to emergence trials. And so this has everything has to be taken into the thing. So what is the ED surge capacity and planning? So prepare for the patient influx and during the outbreaks. So there should be an alternative care set. For example, if your ED is overflowing, you should have an alternate area for examining these patients. And if you think you cannot give service for all the patients there, at least you can give a Tele-Triage and remote consultation where you think the spread is not there, where you can only educate them to take the measures, and should be a dedicated highly infectious zone. So once if you think the patients have been infected and they're highly infectious, you should have a dedicated highly infectious zone so that the containment is contained. Otherwise, the spread can be more. So administration and system level strategies, I said, there should be a universal symptom plus travel screening as we did in the COVID, and standardized isolation workflow should be maintained, and defined patient unity case criteria should be taken, and rapid diagnostic capability should be there. So the rapid diagnostic test at least should be considered for isolation of the patients, and PPE simplification frequent training. So these training by the public health agencies with collaboration with the EDs to sustain these systems. So they should be a regular training drills. So whenever there is a surge of cases you can expect or a pandemic you are anticipating. So I said this diagram again. So the global governance with the system strengthening. So the emergency people with the disease surveillance and evaluation tool along with your leadership and stewardship. You need for all this financing, again, health workforce. It can't be a single man. Everybody has to come into play. Medical products and technologies, information research, and lastly, your service. So everything comes into play for the containment of these highly infectious diseases. So what is the role of ED team now? So it starts from the triage nurse, early identification and isolation. So the physician clinical assessment and stabilization, and the infection control people where supervision of the PPE and reporting, and lastly your admin where have the communication, logistics and coordination. So it is not a one man, so it has the team which comes into play from the nursing to your administration people. So this is the last year surge where we have a H3N2 variant of COVID-19. The virus was G4EAH1N1. So it is Victoria 4897. And there is not much it has done for us. Only a simple symptoms were there. So the mortality was only marginal, and only a basic treatment was suffice for this recent surge. So we'll take some of the examples of all this pandemic. The first example was the Nipah virus. So the presentation will be always with the fever, encephalitis, and landing into ARDS. So it is transmitted through the bats, humans, and can have a nosocomial spread. The ED key actions will be early suspicion in encephalitis clusters, as we saw in the Kerala. Strict airborne and contact precautions has to be there, as we saw, and rapid coordination with the ID unit and the lab. So the Kozhikode Nipah management, what did they do? So the structure, this is the plan they had during the search. And this is the Nipah which was started first in the Malaysia, then last spread was in Kerala, which is in 2023. So if you take the Kozhikode Nipah management plan, it was a beautiful plan. So where the management has come into the play, the government authorities has to play a role. The next is the Ebola. So patients can present with fever, bleeding, unstable hemodynamics. So extremely contagious via body fluids. So the ED approach should be immediate isolation, no invasive procedures unless as essential, double PP and negative pressure if available, and notify the public health as early as possible. So this is the flowchart how you have to screen these patients. So first thing is from the isolation, then from the triaging, from the isolation. So the patient is unstable. So what we do, we are subjecting for them for the hospitalization. If the patient is stable, so these patients have been sent to the home, and from there, if patients need some monitoring, they have been transferred to the healthcare facility. So the re-emerging airborne infections, as we know, we are a tropical country where the tuberculosis and measles spread is rampant. So if you take the tuberculosis, the mode of transmission is airborne, and clues will be chronic cough, hemoptysis, weight loss they can give. So ED approach and precautions, always gear up with your N95 respirator and keep them in a negative pressure room. So avoid your nebulizations, use MDI, and early infection control. And clinical message, what I say, a stable cough patient can infect an entire ED shift. So as soon as you think he needs isolation, say submit the patient and shift him to the isolation room. If it is a measles, so the 3 C's, cough, coryza, conjunctivitis, followed by a rash. So approach should be isolation, notified by the public health for your contact tracing, and a single missed case can trigger a hospital-wide outbreak. So the emerging zoonotic respiratory threats were the avian influenza and your MERS-CoV. So the avian influenza reservoirs are world by bats. Transmission is droplet. Clues are the fever, cough, dyspnea, and rapidly progressive pneumonia. Approach, so early triage isolation and negative pressure, the same thing we should do. And a single unrecognized zoonotic case can expose multiple healthcare workers during the resuscitation. And for MERS-CoV, we have the camels, which has been the source. It is also a respiratory droplet. So same fever, cough, dyspnea, and patients can present with renal dysfunction. And there's a strong travel history should be taken. The same airborne plus contact precautions. This can mimic a community-acquired pneumonia. So this is the pathway of the Middle East, the MERS-CoV. So there is a contact hospitalization. So this has to be when if there is the patient, there's no travel history, there's no need of any worries. same for your, and off late we are seeing for their chikungunya cases. And this is nothing but for your suspected Zika virus. So to summarize the 3 viruses in this form, so MERS-CoV, the key symptoms will be your cough with your breathlessness, and some GI symptoms might be there. Incubation is 5 to 12 days. So the test positive are your RT-PCR, ELISA, or immunofluorescence. Complications are your ARDS with MODS. And chikungunya, we have a polyarthralgia, rash and fever, where incubation is 3 to 7 days, and it is isolated by RT-PCR, ELISA. And complications are chronic arthralgias for months, or sometimes some patients may have a 1 year. And some patients have been reported with your GBS and myocarditis. And lastly, the Zika, fever, rash, and conjunctivitis. It is also, the incubation is 1 week. The tests are IgM serology. Congenital Zika syndrome and GBS are your major complications. So the admission and disposition for a MERS is, admission is same as the respiratory illness. High risk are the older groups, and more with the more comorbs, the mortality risk will be there, so better to admit. Discharge considerations indicate on your droplet and homate transmission. So next thing is your chikungunya virus. Outpatient patient, less than 65, discharge and give your only pain control. Admission indications only when you are suspecting a multi-system involvement. And rule out dengue, hemorrhagic, or severe malaria, because it can mimic these things. And or whoever is our elderly with comorbidities, it's better to admit. So counseling, prevent mosquito bites for the first week, and warn about the chronic arthralgia. And Zika, most cases are asymptomatic. Isolation, avoid mosquito bites. Special populations, pregnant women, high risk, and there should be an obstetrician referral. Severe neurological cases, so ICU admission, and there can be a GB encephalitis. And GB associated Zika associated GB have a faster progression and a shorter plateau phase. So the surge and crowd management in outbreaks. So outbreaks, example, the COVID-19 can lead to a surge of low acuity points seeking the ED care. So crowding impairs the isolation and infection control. So everything, again, what I mean to say is there should be a regular drills or mock drills every 3 months or 6 months. So whenever there is a pandemic, you should be prepared. So separate pathways for low risk versus suspected emerging infectious disease. Tele-Triage and mobile screening has to be implemented. So using electronic records and technology for ED detection. And metrics and key performance indicators are time from the travel to isolation for the suspected infections. The target is less than 30 minutes, and percentage of febrile travel screen for exposure bar travel has to be taken, and PP compliance rates in the highly suspected high-risk cases, number of drills which have been conducted annually. So that has to be one of the key indicator, and number of ED visits diverted via Tele-Triage in your outbreak visits. So these are some of your key performance indicators which has to be taken into consideration. So local adoptions from the Indian ED settings, consider travel from neighboring countries, domestic or vector. So whenever you have an outbreak, so from patients coming from other countries, to take the data, you screen from the where they are landing. This can be airport, you can bus station, or your railway station. And tropical illnesses are common, so laying an emerging infection screening onto existing the overflows. So there should be a liaison with the Indian Public Health local travel hubs for the updates. So these people can give you a regular updates whenever there is a pandemic which is going on and there's a chance of spread and resource constraints. So adapt protocols for isolation, PP, and diversion of low acuity cases. So there will be a problem of resource constraints. So this has to be considered. So integration your ED protocols. So inserted a standard travel exposure screening questions into the triage form and define a suspected emergency infectious disease criteria for your hospital. Map isolation from location and workflow in your OD and identify lead ED staff for emergency response ED team. So this has to be implemented in your hospital and the lead ED physician should take the responsibility of implementing this. So sustainability and continuous improvement, avoid panic neglect cycle. Preparedness must be maintained even between the outbreaks. So there should be a regular drills, how we do the drills of your fire or accident cases. So this has to also be done. And periodic audits, refreshers and policy updates and establishment a committee of ED with plus infection control plus public health every 3 months or 6 months. So the broader benefits, these strategies also protect against the common infection. So it can reduce the healthcare exposure and ED shutdowns. So it creates a culture of safety and negligence. So ethical and operational aspects. So duty to treat versus staff safety. So whoever is working in the hospital, it is our responsibility to take care of the staff. And there should be a balance of with the PP and admin support. There should not be any scarcity or definition of the whether it can be a PPE or the disinfects. And avoid stigma and misinformation. They shouldn't, when a patient got infected with any infectious disease, they should not create a stigma and misinformation should be avoided. And transparent communication builds trust during your outbreaks. So take home summary, the 5 ED preparedness pillars, universal screening. So initial assessment to identify potential cases as early as possible. So we being the emergency physicians, so this will be at our doorstep for the universal screening and where we have to implement or follow the protocols. Immediate isolation. So based on the symptoms, the patient condition, you have to isolate as early as possible because of swift containment to prevent a further spread. And redefined case definition. So precise criteria to avoid unnecessarily alerts. So whenever there's a pandemic, there should be a redefined case definitions, whether the patient is fitting into this criteria or not. And rapid diagnostics. PCRs may take time, at least a rapid CAT method, which can help, which can isolate, which can contain it. So which helps in the patient spreading and streamline PP. So easy to use protective gear for frontline staff. So there should be a periodic drill. So the staff has been joined recently. A regular drill will make them use all these PP or the whatever the gadgets it is used, and the hand hygiene policy should be followed regularly and should be educated and it should be monitored. So these are something which appreciation which I got during the COVID, because it was a nightmare for me, where I worked in a medical college hospital where we were having this COVID for almost 3 waves, where the hospital has treated with the quarantine cases of nearly 20,000 cases. So we did exceptionally well in treating all these cases and having a good outcome. So these are some rewards or felicitation which I got during this pandemic. And so this is some unforgettable gift I got from a COVID patient and from the hospital and my ED department at Narayana Medical College.
Raghu sir?
Yeah,
Sir, thank you so much, sir, for your insightful session. I think the PowerPoint is so clear that you have beautifully highlighted the rapid evolving challenges which we emergency departments are facing with these infectious diseases, and what exactly is the critical role of the emergency department clinician should play in the early recognition, the clinical presentation, and what timely intervention we have to do, what is the patient safety and treatment. I think all these are properly highlighted, sir. And thank you so much for sharing your experience also.
thank you, Shravani.
Sir, I think after this session, no, I don't think there should be any questions to be asked. So I think there are no questions also in the chat box.
Okay.
So
So there are no questions. We'll just wind it up.
yes. So thank you once again, sir.
Thank you.
Thank
Bye.
you for your time.